Can you hear me now?
Yes.
Yes? Okay, good. So what I was saying, I'm concerned that we don't have very many members from this subgroup present. It looks like those that are present are DMHA folks.
Yes, that does look like what's happening.
So we're missing, I mean, Matt Brooks wouldn't be here. Rick Crawley would be though. So we're missing, oh, looks like we just got Scott. Has anybody heard from Steve, Tim, Mimi, or Barb?
Everybody on the list accepted, I believe, except for Barbara Scott.
Okay, and I know Carrie couldn't be here, so I know that. Hi, Scott.
Good morning.
So just for an introduction for the meeting, I think, are we live now? It looks like we are. So this is Katie Adams with Southwestern Behavioral Health Care. This is the Indiana Behavioral Health Commission Continuity of Care Subgroup on August the 10th, 2021. We do have some folks present from DMHA. We can do introductions. I am concerned about attendance today. So I'm curious what your thoughts are about continuing this discussion or rescheduling.
Yeah, it's 5 minutes after. Do we want to just hang tight for another 4 or 5
Sure.
minutes and see?
Yeah, I'm happy to.
Yeah, because I do think you're right that we do need the input of several folks.
Yeah.
Okay.
Okay. Well, let's just hang on then for about 5 minutes or so to see if anybody else joins.
Okay.
I'm gonna mute myself.
I'm going to send a reminder email just in case that's helpful. We'll wait till about 10:40, and if we don't have anybody else join, then we'll reschedule.
Steve is here. Hi, Steve.
Hey, Steve.
Hey,
Just-
sorry I was late. I was at a hearing
Ah,
and it's still going on, but I saw your email, so I switched over.
Thanks, Steve.
okay, so Steve, just to get you up to date, we're kind of waiting. We have low attendance today, so we were trying to decide if we needed to reschedule. I know Carrie Cadwell was not able to make it, and Barbara Scott didn't accept the invite, so I'm assuming she can't either. But we're missing Mimi and Rick Crawley and Tim at this point.
Katie, if you feel comfortable, I think with having you, Steve, and Scott on here, I think that's enough to get
Okay.
things, keep things moving, and then we can send a summary maybe out to the larger group for any modifications, but at least that way we keep the show on the road. So
I'm good with that. I just want to
Okay.
do what's right here.
no, I
So,
appreciate that. I appreciate
Yeah.
that.
yep. Okay. So, so I already kind of announced the beginning of this meeting. For the purpose of introductions, can we just do that real quick? I'm Katie Adams. I'm the CEO of Southwestern Behavioral Health Care.
I
Steve.
am.
Oh, go ahead,
Go
Rachel.
ahead, Steve. Okay. I am Rachel, now Johnson Yates, the Deputy Director and Chief of Staff for the Division of Mental Health and Addiction.
And I'm Steve McCaffrey, President and CEO of Mental Health America of Indiana.
Scott?
Good morning, everyone. This is Scott Fatness, Mayor of City of Fishers. Happy to be here.
Thanks, Scott.
I'm Amy Brinkley with Dmha, just here to support as an admin.
And Kelsey Linville, also playing a support role from Dmha.
All right. So just to kind of, the first thing on the agenda is approve the minutes. And if you can believe it, the minutes are from April, if you can remember back that far. The minutes were attached to the calendar invite. So if everybody had a chance to review those, I guess let us know if there's any edits to that. Okay, do we need to approve those? Or is it just, we're all approving them by saying that we don't have any edits? Okay, let's just move forward. Okay, all right. So just a review. So we met last in April and we had a really good conversation. And we came up with about a dozen of different kind of topics that might be important to focus on for this subgroup. Keeping in mind that this is the continuity of care work group, and we have other work groups working on other things. So what I did with that, because our timeline is short and we want to try to push some recommendations here shortly, is I created just kind of those categories and had people rank them. And as a result of that ranking, we did have a top 4 that were pretty clearly the top 4 items. Not that we have to create recommendations from all 4, but it was just a way to help focus our conversation today on just those 4 topics and what recommendations we might be able to create from that. So if I can share my screen, I have like a little, am I able to just steal and share my screen? I'm going to try to. Yep. So what I did here is just created a document that's going to kind of help me focus, where I'm going to kind of take notes and write down ideas for you guys to see. So I just put the charge here, and this is from the previous minutes and in communications of just what is our focus here. And so our group is focusing on looking at the system through the eyes of a person's journey through the various aspects of the system, focusing on the integration, coordination of care. So part of that is rapid access to high quality prevention, early intervention, and treatment, but it's not just intake, it's also accessing ongoing treatment. So sometimes when we talk about access, we're thinking about intake, but it's also ongoing treatment. So access to the continuation of care, and the strategies designed should encourage collaboration, transparency, and innovation with a focus on equity, social determinants of health, data integration, dealing with administrative red tape, and utilizing technology. So that's like the focus of this group. So what I was hoping we could do is just start with, and I was going to just kind of type in ideas to help us see if we can develop some either low-hanging fruit or kind of high impact recommendations for each category. So to start, the top bucket was treatment extenders. So that's the idea of using peers, non-licensed folks, technology as a way of helping fill gaps in the continuum. So the question is what do we need to recommend to legitimize and sustain the use of peers, non-licensed staff, and technology to fill the gaps in continuity of care? So thoughts on that, and I'll just kind of type your ideas.
Well, I'll just start with what I say at every meeting, so it's easy off the top of my head. I think you can almost put this into two categories. One, we definitely want to maximize the workforce as you're suggesting here with non-licensed staff, and the best way to do that in many cases is through the certification of staff. And so through training and then some kind of quality assurance through certification, I think that is the way that we can assure ourselves of increased competent staff. And I always say this is somewhat self-serving in that MHA is one of the certifying bodies through ICATA, but we do that. We put resources into that because we believe in that. We think that's the way to go. And then the second piece to that that's connected is if you create a workforce that is limited to in-person work, then you haven't maximized your workforce. And so we have to figure out a way to use telehealth for these certified staff people, because otherwise, it's just ridiculous. I don't think I have to explain it, but obviously they can't do as much, but also they can't see all the same people. And so maybe they could see somebody who then switched to telehealth and they can't work with them. So if we're trying to maximize resources, those would be my two suggestions.
So Steve, when you talk about creating certification, so part of this is the existing community health worker certification, but are there other existing certification or ideas for certification that you would suggest?
Yeah, there are. And, I give DMHA pats on the back here. We've had conversations with them and they have, I think, been open to ideas. And so just a few examples. The OTPs are an example that there are certified. There are staff people that DMHA requires certain levels of certification that are not licensed necessarily. DOC requires some level of certification that are not licensed necessarily. The gambling credential is a certification, not a, and I'm of the view, not the point of this conversation, but I'm of the view that with sports gaming, gambling is going to be like the next big thing. It's just a matter of time before that blows up. From our standpoint, and I'm not trying to make it about us, but we offer bachelor's and master's level certifications, addiction certifications for mental health professionals, a KDAC 3 and a KDAC 5. We offer the KDAC 2 and the KDAC 4, which are the bachelor's and master's level addiction. We have a prevention credential. And we are talking about, with respect to peers and recovery coaches, we're talking about creating endorsements based on the need. So for example, you may see an endorsement that we offer that's a forensic recovery coach. And so that'd be for people, obviously, that are involved in the criminal justice system. And it's funny, the more you talk about this, the more somebody will come to you and say, hey, we need somebody with expertise in this, that, or the other. Why doesn't somebody do that? And, we've taken the position that that is the way to maximize the resource, and we plan to do that. And, we're all for, and, MHA passed the loan forgiveness program for mental health and addiction graduate level programs and licenses. So we support that, but that's going to take obviously years to get to a place where we can expand the workforce. This is the way to do it immediately, and immediately is when we need it.
So Steve, what you're talking about is many of these certifications currently exist. Which ones do not currently exist?
I'm sorry, my internet just became unstable.
Oh.
I heard the last part of that.
Oh, some of these certifications you mentioned that I kind of jotted down currently exist. Which of these
Yep.
do not exist?
So I named some of the ones that exist. There are others that I like. I don't consider this to be a comprehensive list. But the endorsements based on the future need, those do not exist. And of course, all of this is tied to reimbursement. So we can offer certifications till we're blue in the face, but nobody's going to get them unless there's reimbursement for them. Community mental health center is not going to encourage, well, they might, just because they believe in good practice, but they may or may not necessarily encourage staff or pay for staff to go for training and certification if there's not reimbursement for it. And so in my example of OTPs, that's an example where DMHA has said, these are credentials that are appropriate for OTPs, and OTPs can get, payment with those staff people. But that needs to be like a comprehensive, in my opinion, a comprehensive strategy where, it can be this committee or DMHA, however it happens, but what are the services that we have along the continuum? What are the ones that fit, credentials that we currently have? What are the gaps that we need to build? And then how do we reimburse for all of those credentials? And if we do that, we're probably going to see an increase in the workforce. And if we don't do that, then it's just a nice thing for people that are interested in self-development.
Yeah, well, and this, everything connects with each other, right? So this does connect to the workforce group, and just talking about this career ladder that,
Right.
You can't just go straight to a master's all the time.
Right.
So, or a psychologist. Okay. So some kind of points here is looking at endorsements or certificates that could be added, but then also making sure that the certification is tied to reimbursement that can sustain that position.
Correct.
And then the maximizing use of telehealth, it all kind of fits under this, right? Is the certification should also include being certified to provide those types of services via telehealth, or
It
indicating
does.
what types of services could be
It
provided.
does. And just as a reminder for everybody, the Senate Enrolled Act 3 allows for telehealth scope of practice and reimbursement for licensed positions, which is great and we appreciate and we supported. But and there was discussion about adding certification, and the thought was, let's walk before we run on this, and let's make sure that it works with licensure before we expand it, which I understand that logic, but it also at the same time impedes what we're trying to do. And so in my view, that needs to be the next step.
Right. Okay. So Steve, you kind of had many of the same thoughts that I had on this topic. Does
They must be
anybody
right
else have?
then.
What?
They must be right then.
Well, of course it's right? If two of us agree, then that's right. I'm curious what people think about the use of technology. I mean, there isn't a ton of great research really saying, yes, for sure, this is a great fix for the gap. There's also a question about how many people can really access some of that technology to fill in gaps. And by technology, I mean, not just like having access to Zoom to do sessions, but also having some of the apps like My Strength, Calm. I mean, there's a bunch of different apps that people can use in between sessions or visits. Does anybody have any more thoughts about the peers or certifications or use of technology?
Well, I don't want to be the only, I don't want to dominate the conversation, but I would just say, and obviously we have to use technology that is appropriate. But you're right, you can't, there's not evidence-based research to tell us what that is because it's all an emerging practice. But I do think as a philosophy, at least my view, is there needs to be many paths toward treatment, and treatment can be and should be as individualized as the client's needs. And there are some people that prefer, just like, technology for anything else. Some people, like Facebook, and some people hate it. And so you catch people where they are and what they're comfortable with, and you're going to have good outcomes.
Yeah. So I just put down, just further exploration of technology as an emerging practice. It's something we don't want to ignore. It's probably a part of the piece. It's just not something we necessarily know enough about or enough people have access to. Any other thoughts about this first bucket? So, I mean, I think that what I wrote in here is we could craft a recommendation pretty easily from these notes, don't you think?
I do.
I mean, we could do that probably without much difficulty. But just another opportunity for anybody to make any comments about this topic. All right, well, let's move on to the next one then. So the next one is access issues. And so again, it's not just access for intake, but just access for ongoing treatment. I know one struggle is yeah, I can get you in same day for an assessment, but you can see your therapist 6 weeks from then, and that's just not good continuity of care, right? So, so there's several pieces to this. What the administrative burdens that's keeping us from having good access, workforce issues. Silos, I think, is a big issue. People running into, you're in the wrong door, you got to go here kind of issues. So what do we need to recommend to address issues related to access to intake and ongoing care? Thoughts about that one? So I can start, and I hate to say workforce issues because there's another group working on that, but really when you think about access right now is we just don't have enough horses. So I think workforce issues, which kind of go back to the other item that we just talked about, using other types of non-licensed individuals to help fill some of that gap. So it kind of goes back to what we just thought would be a recommendation, is workforce issues. Another thing that I would say is communication is difficult between different levels of care. Like, for instance, we may not know that somebody was hospitalized in Terre Haute, and we don't find out that for 3 months later. But if we would have known, we would have followed up with them after hospitalization. So part of it is just being able to communicate between systems, and HIPAA and 42 CFR are big barriers to that. And using the same electronic record or being a part of iHi is a big barrier to that as well. So there's no like centralized-ish way of sharing information. So I'm just going to kind of put that in as just like communication issues, data sharing between levels of care. iHi participation requires, it costs money to participate in iHi, and it requires an IT infrastructure to be able to do that too. So I don't know if money is a barrier for smaller shops or any shop to participate in some of that data exchange.
I think it definitely is money and resources, being not just financial, but also expertise. I mean, frankly, one of the issues we have, and I don't know that there's a solution to it because it's true with every area, but generally speaking, people that are really good at being counselors are not typically really good at technology. And if you have to use technology, which nowadays you do, that's a struggle.
It is. But that is a big barrier for continuity of care, moving throughout systems, and even with just talking about integrated care is we're not all speaking the same language, and we're not all speaking in the same system. So it's hard to provide a good continuity of care when there's so many, lack of phone calls or hung up phone calls.
Mm-hmm.
That makes sense.
I think, I see it as your question in number 3, and like you say, all these merge together, but credentialing really is a barrier to access to.
Yeah.
And I don't know if I don't, there have been many conversations about this and legislative action, and Dmha or FSSA was going to have a single point of entry, if you remember that, and then that didn't happen. And I guess the fact that they can't figure out how to do it kind of makes the point that it's ridiculous. And I think it's hard to argue that you can have somebody that's credentialed one place and not another, one location, not another, and they're not able to see somebody in a different geographical location. I think it's hard to argue that that's a good policy strategy. All that is the barrier to access. And so, I think that's a huge issue, and I'm not sure what it takes to get that dealt with, but that's a huge issue.
Steve, this is Scott. What are the forces against that? So who are the vested interests to see it stay status quo today?
I mean, I think, like so many things, there's a legitimate piece and an illegitimate piece. So if you have an insurance company or multiple managed care companies, they all want to do everything the way they do it, and they want to assure accountability the way they want to do it. And so if you have a bunch of insurance companies and you have a bunch of managed care companies and Medicaid, and everybody does it a little bit different, and you have to do it all individually, that just is ridiculous. And so like I said, Scott, there was a bill that we passed several years ago that basically said FSSA, and they said that they were doing it. And so we started out being a mandate, and then we changed it to, it was a nice statement of something, and because they were doing it anyway. So I think, and I don't know if anybody knows more than me, and if they do, they can say so, but I think they went about the business of trying to contract with a vendor to put it together, and it fell through. And at first it was delayed, then it fell through, but it's a huge, huge problem. And again, the smaller you are, the harder it is, and more expensive it is.
Mhm. Yeah, and I can just share, recently I got an email from our accounting department about one of the managed care entities and how we've been struggling to get payment for a year now on clean bills. So, if you're a smaller shop, that's just, you can't wait a year for your reimbursement,
Right.
And there's just, and they're clean bills, it's their error. But there's no accountability for that. You just have to get what you can get, right? So, I think multiple managed care companies with just different processes, they have different requirements. Their credentialing is different. Their prior approval process is different. Their definition of medical necessity is different. So having some kind of, Indiana standard for these things, I think would be really helpful. That is in line with other, medical specialties.
Yeah. And so Scott, in my view is there's a legitimate piece about accountability, and there's an illegitimate benefit to the payer that they don't have to pay. Right. Or at least they don't have to pay quickly. And then that saves them money. Like there almost needs to be a penalty that if you had a penalty where if you weren't credentialed within 30 days and then you paid a surcharge for every day that you weren't credentialed, or like in your case, Katie, if it was appropriate and it took a year to get it paid, then they had to pay a surcharge for that 365 days. That's the way you could change it, I suppose. But I liked the single point of entry idea the best. I mean, that's like the smart, logical way to do it.
So Steve, that would be some sort of agreed upon standard, and the small shop or the small private entity would submit their billing to like a middleman, so to speak, for the state of Indiana. And then all of these other managed care or insurance companies, they would just have to deal with that, the middleman, so to speak, because you would have agreed upon a standardized approach for all providers throughout the state. Is that what I'm hearing?
Well, that'd be interesting, actually. So there are actually two pieces. There's the credentialing piece, which is really what I was talking about. But you're right. The billing piece is a big problem, too. So the credentialing piece is they take a while to determine that your therapist
Right.
can even bill, for that payer. And you have to credential them for all your payers. So there's that. And then, you're on the billing piece, it's also very complicated, and you have to have a billing department, and that's just administrative burden that prevents people from getting services. So if there was a middleman that you could just do all the billing for everybody and it was easy, that'd be wonderful.
Interesting.
Well, one thing that was, I think it was communicated in the notes maybe, or maybe it was, I don't remember how I communicated, but there's a model in New York where they tackled this issue of parity. And so there's sort of like a blueprint, I think, that they have used to address some of these issues. And I'll be honest, I haven't gone through it with a fine, tooth comb, but that might be part of a recommendation, is to see that blueprint in New York and how we could use something like that here in Indiana. Does that seem reasonable?
Yeah, and I will say, just for the committee's information, which may or may not be relevant, but the Commission on the Status of Children has a committee on parity, which I chair.
Oh.
And it resulted from the Kreider bill from a couple of years ago. I'm not remembering the number off the top of my head, but basically Senator Kreider had a bill that was modeled after the model that is used around the country on parity implementation. And then the parity committee of the Commission on the Status of Children is like acting like a stakeholder group to work with them. And to the Department of Insurance credit, I've been really pleased with the way they've gone about it. They're doing reviews of the insurance policies to see if they comply with the parity law. And then they're doing reviews of the companies in Indiana that to make sure that they're actually doing what their policy says. Now, the sad part of that is it takes forever. It's like, I think it's over a year now. But it's very legal and technical and hard to do. So anyway, long story short, by fall, they're supposed to have their completed review, and it gets legal. Like, there are things they can tell us and things they can't tell us because they don't want to tell us anything about a particular company that then would sue all of us. But the hope is that there'll be the ability to have some recommendations if needed because companies may or may not be either in intentional compliance or unintentional compliance, which is also possible. And then we're supposed to report that to the Behavioral Health Commission as well. And then a side note to that I haven't figured out how to respond to, but the commission asked, and I mentioned this to Rachel so she knows, but the commission asked that we think about parity through the lens of not only are the financial and treatment requirements in a technical sense parity with medical disorders, but also is it, from an impact standpoint, is there equity in special populations? And so, and that's harder. It's harder to measure. It's hard. And to be honest, I've talked to a lot of people in the state, and I've talked to a lot of people nationally, and nobody else is looking at that. So I think that's like a neat thing if we want to try to be a trendsetter in that regard. I'm not sure exactly how to do it, but we're developing a subcommittee of the parity committee to take a look at that. And our hope is that we'll be able to do something that's meaningful.
What was the name of that group? I missed it, Steve.
It's the commission, you mean? I always forget the whole name, but it's the Commission on the Status of Children, on improving the status of children, I think. And it's run through the Supreme Court.
Okay. Awesome. Okay, so it sounds like in the fall, there might be some recommendation to the Behavioral Health Commission.
Yes, that's the plan.
Awesome. Okay, well, that's really good news.
Yeah.
Okay, so some work's already being done. So we kind of jumped to this parity discussion. And I think that we kind of covered it, but there's kind of two big things that I heard, correct me if I'm wrong, but there's this New York blueprint that we can kind of look into to see what they did. And then there's also this work done by this Commission of Improving the Status of Children, and we can see what they recommend this fall. Are there other things related to parity that we could talk about or recommend?
What is the current posture for enforcement of parity issues in Indiana? I mean, because it's one thing to pass a bill that says there shall be parity. It's another thing entirely to dedicate the resources and the time to pursue what is perceived as a lack of parity and the ramifications for not addressing it once it's been identified. So do you guys have a good feel for where we're at relative to other states in terms of enforcement or oversight on parity?
No, that's a really good point. And I will just say, Scott, that the federal parity law does not designate who the enforcement mechanism is, and the Indiana statute does not. The assumption is that it's Department of Insurance, but they would tell you that no one has empowered them or designated them or given them the resources to do it in a significant way. My hope is that at the end of this review, that will be a logical outcome, and that might be one of the recommendations, that they will be empowered and have the resources to do it. For what it's worth, the new insurance commissioner was the deputy commissioner who was working with the parity committee before she was promoted, and is totally bought in on it. And so I think that makes sense. But I think people do complain to the Department of Insurance, but again, they just kind of do it ad hoc. So if they had a department or a designated person or whatever that comes out of this recommendation, I think, and people should know, if you don't think you have parity in your insurance coverage, who are you going to call? And there should be a number, and we should be able to promote it.
Well, that might be a actionable item from our committee on continuity of care, potentially as at least something we could support moving forward, is some dedicated resources to, if for nothing else, just execute and implement the laws that have already been put on the books.
No, I like that.
I do too. Other thoughts about parity? Okay, so the last big ticket item was the crisis continuum. Just recognizing that there's gaps in rural areas, outreach and engagement when people are getting out of the hospital, state hospital, jail, prison, crisis units, and just funding CCBHCs. So what do we need to recommend that would allow all Hoosiers access to the full continuum for crisis care? Thoughts about this one?
So I don't know if you want to restate it, but to me, your recommendation number 2 on the CCBHCs, to me, that's a significant solution that solves so many problems, because in one step, it provides more access, evidence-based services, and higher reimbursement. So to me, that pretty much does it all.
Yep.
I shouldn't say it does it all. It does a lot.
How does this interplay with the 988 $100 million, emergency response coverage throughout the state that DMHA is currently considering when it comes to crisis and that continuity of care?
So I've been in the 988 calls, and so the 988 is going to be like a centralized call center. But the issue is that if somebody needs more than a phone call, it's going to have to be deployed locally anyway. So the question here is more about how are we going to provide those local solutions and touches for those in crisis. The phone calls are great, and I think it probably handles 80% or 90% of the problems. But for those that need more than that, in the cities, I think the bigger cities, it's maybe less of a big ask, but for these rural communities, it's really difficult. And then you get the workforce issue. But I agree with you, Steve, that really, when it comes to the crisis continuum, if we can fully fund, certify, and support CCBHCs in Indiana, that would be a huge step towards having a truly a full crisis continuum.
Yeah, the issue, Scott, so just to build on what you're saying, that it's important to have a 988 and crisis care and a full continuum, but it doesn't do any good if you don't have the full continuum. And so like you can call 988 all you want, but if there's no place to refer, there's a problem. And so our thought process, so I'm speaking for MHA, but I think it's generally accepted, is that 988 is a really good reason, or it's a really good hook to say we need the full continuum of care. And so let's build it out and use 988 as the reason to do that. So I think it's a huge opportunity that we're calling 988, but it's really building out the entire service system.
And do you think that service system will be in the community behavioral health centers, funding those to staff 24/7 response and crisis coverage? That's a component of it.
I think they're looking at that now, but there's a lot of existing crisis lines, I guess, for a better way of so right now they're talking about how those would be folding into that. And you're right, all community mental health centers have 24/7 crisis of some sort. So how does that officially integrate with 988?
Rachel, were you going to correct something I said?
No, I
Or
had a
something I
question.
said?
No, no corrections. Forgive me if you guys already talked about this because I had to step away for a moment. Have you talked at all about information sharing or data sharing yet in this conversation?
That's here.
Okay.
We did, but if you have a specific recommendation you'd like us
No.
to,
Yeah, let me add to it, Rachel.
No, I think the iHigh participation is a big part of all of this, because I'm thinking about and perhaps some sort of, and feel free to push back on this. You know, I think what we are missing as a system is, number one, effective and ethical data sharing, and then number two, some sort of centralized case management. And that is something that can be done through partnership with the MCEs potentially. There's opportunities to do this differently than how we're doing it now. And I think part of the problem is, the MCEs right now are doing case management. I think we have some issues where CMHC case management may not totally understand what that is or how it might benefit the client. And so then clients are, of course, falling off between different levels of care. And some sort of a centralized method of just like tracking and supporting the clients and seeing where they are, how they're doing, and keeping in touch with them. And I think that's one of the hardest parts, is that when people are transitioning between agencies or levels of care or treatment teams, that they, that's where we're losing folks a lot of the time. And then, I think from what I have seen, that often is a large contributing factor to why people end up in crisis, is because they've fallen out of these lower levels of supportive care that they needed along the way. So, okay, cool. I'm glad you guys already talked about that. I wanted to make sure that we had mentioned it. But yeah, so those are the big things that I was kind of thinking of. And as you were talking about crisis, I was thinking about all of the steps prior to crisis that we could do that we don't always perform highly in general as a system, that have a lot of opportunity for improvement.
Yeah. So, we didn't come up with like an actual recommendation on this, but basically in my mind, I think iHigh is huge. And so the recommendation, I think, would be more about, investigating the barriers to participation and figuring out what those are. I mean, I think that would take like a deeper dive, because smaller shops can't do it because they don't have the IT infrastructure, or they don't have the money, or they don't have the expertise. I know our struggle with iHigh is since we have Stepping Stone, it's designated as an addictions place. So we can't share information because of 42 CFR. So we can get information, but we can't necessarily share it.
So what I understand, Katie, is that there were some recent changes to 42 CFR that make SUD data information sharing more more easily possible, I think. And so that's part of something that we're starting to have some preliminary discussions around. And so,
Yep.
You know, a recommendation that I might suggest, and feel free to wordsmith it, would be something around exploring and developing a shared data system, specifically in terms of like dates, level of care, and medication. You know, I'm thinking like it's not necessary for, and maybe I'm wrong, it's not necessary for the treatment team at a local jail to have the information about, like, you know, the person's childhood processing of childhood trauma in a session, but knowing what medication that they're on and where they've been in care before would be really helpful.
Well, and just admission and discharge dates, just the dates are
Yes.
helpful.
Yeah.
Just knowing somebody was admitted someplace is helpful.
Yep.
I do think from a community paramedicine program, we struggle with this mightily in that we're going on all behavioral health runs with our EMS duty officers. And we have access to iHigh for physical health issues today. So if we go on a run and we need to access someone's information to understand their medical history, we can do that today, with the exception of these things around mental health. And that is really a frustration for our team, because a lot of times that information can be very helpful either in that moment or frankly in our follow-ups. So when we're connecting with those people and saying, you know, we know that you've seen so-and-so, or you've still seen them, or you go into your appointments, whatever. I wouldn't want to leave out that group, those emergency responders on the medical side. I know police is a whole different animal, and that gets weird for a lot of folks, very uncomfortable to have them. But from a paramedic perspective, especially for being proactive on these crisis situations, including them in the sharing of this information would be extremely helpful.
I agree.
Okay. Well, we went through all 4 topics. I'm just going to go back for a second here. For the treatment extenders, you know, I feel like we're really close to creating a recommendation for that. Was there any other thoughts about the treatment extenders before we move on? Okay, and then with access issues, we were talking about, you know, the data sharing and centralized case management were the 2 big pieces there. And the administrative burdens, and I know DMHA is doing the intake experience and kind of working on that, and then the credential issues are really dealt with below, but this is kind of a, you know, really rough draft of a recommendation here. Any other thoughts about access? Okay, and then with parity, you know, we kind of came up with 2 things. One is to, you know, look at this New York blueprint to see if there's something that might be helpful for Indiana to take on. And then the other is to kind of wait for this Commission on Improving the Status of Children, see what they recommend, and see if there's some sort of recommendation in there that helps us empower the enforcement of parity as it relates to credentialing and medical necessity and prior approvals and all those things. And then the last one was really mostly about CCBHCs, making sure that the state supports and funds and moves towards Medicaid supporting the payment of that model.
And Katie, the only thing that I might add, and I don't know if it's even appropriate because it might fit in more in the criminal justice subcommittee, but when you talk about continuum of care in criminal justice, we're never going to have a continuum of care as long as we have a bunch of different systems. And, you know, one of the things that I've mentioned in the criminal justice subcommittee is an 1115 waiver like Kentucky has sent in regarding Medicaid reimbursement for behavioral health while incarcerated, and or using the Ohio model where they don't terminate or suspend upon incarceration, but you essentially change the policy that you're on, so that you go from a community-based policy, and then when you're incarcerated, it moves to an inpatient policy, and then when you're out, it goes back to the community-based policy. So it's totally continuous service. They just change the policy type.
That's a great one. That definitely is a good one too. Okay, so there was these two kind of written out recommendations on that survey, which both fit exactly what we've been talking about. It's just wordsmithing what we want to say. So I have a suggestion. Since we have low attendance today, I'm wondering if perhaps we could send out an email to the group with a couple of draft recommendations for each category and get feedback from the group by email. Does that work?
Yep.
Yep, that works for me.
Okay. So why don't I mean, what I can do is I can draft a few statements in each category based on what we talked about, and I promise you it won't be right unless somebody wants to own something and draft it. Does anybody want to own drafting anything in any of these categories? Okay, I'll own it then. So I'll just create, 2 or so recommendations in each category, and then get feedback from the group about wording it different. And then from that, we'll have like 8 recommendations probably, which may be too many. So we can also prioritize those, or maybe some of them will be connected. Does that work for everybody?
That works.
Yes.
Okay, well, I will get that email out by the end of the week then, and then we'll just ask for like a 1 to 2 week turnaround. And then hopefully we don't have to meet again before the next commission meeting. Hopefully we can just handle this by email.
And I'll just say, as somebody who's on a couple of these committees, and I don't know, Rachel, if you agree, but in my opinion, at least, it's not a bad thing that, like, it would not be a bad thing if you had 8 recommendations or whatever you're going to have, and 2 of them overlapped with another committee, and then the other committee has 8 recommendations, and 2 of those overlap with another committee. I mean, if they're all integrated, it just shows we're like, actually, we're on the right path.
Yeah.
Yeah, and I think there's a way that we can synthesize some of it to have it appear as if we've been communicating with each other as well. So I think once we get the recommendations, I think we can be skillful in saying this was actually a recommendation from X committee and X committee.
Awesome.
I think that sounds great.
Yep.
All right, anything else for the good of the order?
Thanks for leading us through it.